Good afternoon, everyone, and welcome to the Be Well Texas Behavioral Health Echo. Thank you all for joining us today. My name is Shreya Prasanna, and I will be facilitating today's session. Before we get started, please note that we are recording these sessions for future distribution. Please note that anything listed in the chat will not appear in the recording. And I apologize, I did not know my video was off. I apologize for that. These sessions are enabled for live closed captioning. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on three dots or more menu at the bottom right of your Zoom screen to find this. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, select the speech bubble icon on the navigation bar at the bottom of your window. To all the Be Well Texas providers, please make sure that you identify yourselves during this session by entering your information into the chat, or if you're joining via phone, please email your phone number and name to bewelltx@unisco.edu. We appreciate your support in helping us fully capture this record. We encourage everyone to join by video for the discussion portion of in the latter half of the session. That said, regardless of how you showed up today, we are just happy you're here and learning alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by phone, please use *6 to unmute. If you join by computer, your mute button is about bottom left of the Zoom controls. You can also use the emotions menu in the bottom right of Zoom screen to raise your hand and indicate you have a comment or question to share. You can also use the chat. There are a lot of us in the space, so please keep your comments brief to allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or the discussion. Towards the end of the session, our wonderful ID support Karen will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions and to address your priorities. And it also allows you to access free continuing education credits. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on client engagement strategies for effective interviewing and retention, and will be presented by Dr. Katherine Dondanville. Following that, we will discuss a case presented by Sharon Hadley. We will start with introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you again for joining us today. These sessions are what we make of them. We encourage you all to share your perspectives and insights in today's conversation. And with that, we will move on to some introductions. Dr. Antoine.
Thank you so much. Glad to be here today for this very important discussion. And thank you all for taking the time. I'm Dr. Dennis Antoine, a psychiatrist from Baltimore at Johns Hopkins University. And I work in a few clinics in the Johns Hopkins University space that treats individuals with both substance use disorders and co-occurring psychiatric conditions.
Thank you so much for joining us today. Dr. Aguilar.
Hello, thank you everyone for having me. My name is Clarissa Aguilar. I'm a licensed psychologist by discipline, and I'm also the Director of Psychology and Training at the Center for Healthcare Services, the local mental health authority for Bexar County, where we provide integrated health treatment for individuals with substance use disorders and co-occurring psychiatric disorders, severe mental illness, and individuals with intellectual disability.
Thank you so much for joining us today. Dr. Dondanville.
Hi, I'm Katherine Dondanville. I'm a clinical psychologist and associate professor at UT Health San Antonio, and I direct the Strong Star Training Initiative. My focus is on helping getting things that work, like evidence-based practices, into community settings. Thanks.
Thank you so much. Julie Parrish.
Hi everyone, Julie Parrish. I am a rehab counselor and the ECHO program manager here at Be Well Texas. Thanks for joining us today.
Thank you. Andrea Hebler.
Hello, everyone. My name is Andrea Havler, and I'm one of the program coordinators here at CSTAT. Happy to be here.
Thank you so much. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm a CSTAT program coordinator. Thank you for joining us today.
Thank you so much. And with that, do we have Sharon Hadley here?
Yes,
Hi,
I'm here.
Sharon. Yes.
Oh, I'm sorry. I am I introducing myself? I'm Sharon Hadley. I'm a woman in long-term recovery, and I have the privilege of being able to present up here today.
Thank you so much, Sharon, for joining us. And with that, we will move on to our didactics. Katie, you can take it away whenever you're ready.
Excellent. Well, thank you for this opportunity. I'm going to share my screen. Awesome. So today we're going to be talking about client engagement strategies for effective intervention and retention. We don't have any relevant financial disclosures to share. And our learning objectives are to discuss 2 keys to readiness to change, describe change talk versus sustained talk, and apply a strategy to elicit change talk. So one of the things that comes up is we feel stuck. The case last month, we felt stuck with. We feel stuck, our clients feel stuck, and they're in our offices. We still have an opportunity. We hear things like, yeah, but, or ambivalence. And this is part of that feeling stuck and that ambivalence, feeling 2 ways about something. And it's a normal part of a change process, but it can also be something that we start to feel frustrated with our clients. One of the things we want to talk a little bit about is, motivational interviewing. It's directive, it's client-centered, it's a method for enhancing that intrinsic motivation for change by exploring and resolving that ambivalence, those 2 ways. It's also a way of being with a client, not just a set of techniques for doing counseling. And so when I think about motivational interviewing, I think about it as the air that I breathe as a therapist, and I can be doing interventions like relapse prevention and motivational interviewing. Motivational interviewing is the kind of the cornerstone of the things that we do. So we want to talk a little bit about the keys to readiness. I joke a lot about this, but I've never had a client come into my office and say that they would like a 5-point reduction on their PHQ-9, right? The things that we use to measure progress aren't necessarily the way our clients communicate what's important to them, what they want. And so one of the things we have to think about is listening for importance. What's important to them? What are their goals? What do they want difference? And also confidence. So confidence could be about whether I think I can do something. It could be confidence in the treatment plan. This isn't going to work for me. I've tried a lot of things. Or I just never do things right. So we want to think about what are we hearing from our client about what's important, and how is that aligned with what we're trying to talk with them about? And are there challenges around that confidence? The core principles in motivational interviewing are expressing empathy, developing discrepancy. We want to roll with that resistance. We assume that there's going to be that yeah, but, and supporting the self-efficacy for clients. We want to help clients make the decisions that are best for them, move closer to their goals. So how do we do that? Thinking about eliciting some change talk. One of the things that I'm gonna kind of present are different types of examples of change talk. So some of that is, querying extremes. Suppose things continue on, right? Then what? We want to look into that future. Looking back, tell me about your marriage, career, used to be before that substance abuse. So looking back, what happened before? Looking forward, if you had a week off from these symptoms, what would you do first? So really thinking about kind of helping our clients access this type of wondering. Another thing that's really important in eliciting change talk is thinking about, do any of these important pressing issues, crises, have anything to do with substance use or alcohol use? So we hear a lot about, difficulties in relationships. Is we want to think about, tell me more, help me understand. When did it start? Are there times in which it's worse or better? It's our job to think about, how do we connect the dots? Another key area is this decisional balance exercise. So we want to look at, first, what are the pros of not changing or staying with the status quo? Like, how is that working? What might be the cons of making a change? What are the potential benefits for that change? And, what might be some of the challenge in the future if you don't make that change? So really thinking through, kind of making space for how things are working, how things aren't working. So let's kind of go through an example here. And this is something that we heard in the last case last month. I don't want to be here. I don't want to take medication again. I don't like it. I'm so sick of nothing working. I just want this all to go away. I think this is probably an example of something we hear a lot in our settings. And when we would, this is sustained talk. I don't want these things. So how might we respond? So one response is just straight reflection. You don't want to be here and you want to be left alone. There's absolutely nothing bothering you, right? We're amplifying that reflection. They're in our offices. You might reflect feelings. You're frustrated. People will not leave you alone. Okay. We also might use some strategic responses, emphasizing autonomy. I know coming today wasn't fully your choice, but you can choose whether or not you want to talk. This is your time. Agreeing with a twist. You're totally fine. And your mom and other people who care about you have no reason to be worried. Just waiting, right, for a response. A running head start would be, I hear that you don't want to talk or be in therapy. Makes sense. It's not easy, but what could you get out of it? So we're joining around kind of what that client is saying and strategically responding in a way to give them space. Affirmation. Sounds like no one's listening to you. No wonder you don't want to talk. Values. Tell me, what's the most important thing in your life right now? If you could be doing anything in 2024 or after this program, what would it be? These types of questions really give us more information that we can work with and open up with our clients and help kind of move towards that change talk. Here's an example of a decisional balance for this client. So we would ask, what are the pros of not talking in therapy or not going to therapy or not taking medicine? Well, I won't have side effects. I wouldn't have to feel these bad feelings. Okay, then we want to ask, what might be some of the cons of therapy? Right? What are the potential benefits? Why would people like me even have a job? You know, what are the potential benefits? What might be some of the challenges you might face in the future? Okay. So one of the things I want to kind of open up to the group and think about, like, think of our clients we feel stuck with, and think about, what do we wish that client would do? What do they actually want? Why do we think they're not doing it? What do they think is getting in the way? So as we're kind of here together as a group, I can't see the chat or anything anymore. But let's think a little bit more about kind of how, what are the things that are coming up as we think about asking these questions to change shock, and we think about, like, what are clients that we feel really stuck with? Yeah. What are some of your observations, thoughts, questions?
I can comment briefly on a client we have. This particular client is very difficult to the point that this client has a reputation at the psych hospitals that precedes this client, and he's really bad hygiene. This client, it's in urine and fecal matter and stuff like that. And basically, I find myself, dealing with staff and nurses who, they're just looking for a reason to cancel the appointment, or say this client refused treatment when that's not really what happened, but they're just such a turnoff. And I don't know, this client doesn't act that way with me so much. Like, when I'm interacting with them, they're very sort of telling me what I want to hear. But because they're so revolting in their presentation, nobody wants to deal with them. And so that's an example of somebody that's probably the most difficult one we have.
Well, and I think probably where we want to join is, like, what is getting in the way of this person's hygiene, right? That is what is making this barrier. And wondering, like, what do you think is getting in the way? That's a pretty I don't know what the right word is, but alarming presentation. We don't come across that presentation that often, because there's so many social norms that kind of lead to most people having some level of hygiene that doesn't include fecal matter or the smell of urine, right? That the hygiene could be not as good, but that's pretty extreme.
It is, and I'm just sharing the publicly shareable parts of this. So it's a very revolting presentation, and basically when I talk to the client says that they don't care. They just don't care. So that's sort of a crust, if you will, to this presentation. It makes it very hard to make progress.
It also successfully keeps people away from them.
Yeah, it does.
Right? So, and that may not be intentional, conscious, but it is what is happening, right? And so, like Diana put in the chat something, admitting they actually need assistance. So which is interesting, right? Because it's like, well, we're seeing them, so they're here. And so some of, Diana, what I would wonder in that case is like, so if you needed support, what would that mean? What would that mean? If you did care, what would that mean? You know?
Oh, yeah. It's really hard. It's kind of beyond me.
Yeah.
I have no idea. You know, it's somebody who refuses has a lot of medical issues too, goes to the emergency room, refuses care, pulls off IVs and walks out. So just, I mean, I think that progress could be made, but it's kind of like, I can't do everything myself. And there's such a turnoff to the home health, to this, to that, you know, so that the support people that I normally depend on, they don't want to go there. They don't want to see this person. And so the person doesn't get the care they need.
Yep. Right. That unfortunately becomes so, you know, thinking about like, you know, the examples also in the chat, like they need assistance or trapped in this rumination. It's like, well, there's absolutely nothing that you need from me, right? Or, you know, when clients are trapped in rumination, you know, it can be helpful to think about like, okay, what are the ruminated thoughts about? What are they worried about? And like thinking about if those worry thoughts, we could ask a question like, if you had a week off from that worry thoughts, what would be the first thing that you would do? You know, like thinking about kind of what is the content? How are these symptoms, you know, impacting them? And how do we help them access what's important to them? You know, I wonder, like in Ralph's client's case, if that knowing what my goals are, what's important, I don't even know. Like I'm just existing. And that's a hard question. So, you know, really kind of helping to think about like, you know, what might things look like, right? Like, tell me about how things were before. Looking in the chat, the person may have a moment of, I don't have anyone else to do for the day. So maybe they just have something else. They may want mental health.
I feel like the client wants people to, you know, change their diapers and do all those things. It doesn't want to even try, and because it's such a stressful environment, the people who would normally help feel very discouraged, and so they don't do as much as maybe they could do, because there's also a sort of a sexual harassment aspect to this, way the person behaves. So so we had this, like I said, I don't have the answers to this one, but I'm somebody who's an eternal optimist. So I'm always looking for the pony at the bottom of the manure pile. You know, I'm somebody who tries, but that's pretty different from how pretty much anyone else experiences.
Well, and this is a hard case, right, to keep trying with. The other thing I think when we think about motivational interviewing is it can be helpful when there's stuckness in a system among a clinical team to think about like, okay, so what do we wish? What do we think is getting in the way? And I think that can also help us with our own ambivalence. We can start to kind of get into these patterns, and you know, it is frustrating, and certain clients are going to trigger us in different ways. How do we like recenter and think like, oh, the but is normal.
Right.
That doesn't mean that I'm not doing my job well because I haven't convinced them. But taking that step back in the setting can be really, really helpful to think about, like, okay, like, we're all stuck, right? The client's stuck, we're stuck as a treatment team. Let's think a little bit more, like, what's important to this client?
Maybe somebody
it-
has some examples of
Yeah.
clients that had really bad hygiene, or that really, didn't take care of themselves and kind of turned their way, turned it around, or saw it turn around. I don't know. Maybe that could be kind of a inspirational story that I could share with people, if anyone has seen anything like that.
Yeah.
Probably not, but
I can
anyway.
jump in
Yeah,
just with
Dennis,
kind
yeah.
of thinking of time. There are oftentimes individuals come in who have medical issues that have gone not so great. I actually had a person who came in and was always struggling to come in, and was having difficulty breathing, coming in late, and we all felt stuck as a clinic to the point where people were putting them to the side. For a while there, I just said, all right, let me just give you 5 minutes to sit down and breathe. Thanks for coming in. And then that led to her coming back more and more. The interesting thing is, over time, as just saying thank you and appreciative through the difficult times, we found out that she needed a primary care doctor. So we got her there, and then did a little bit more, and then found out she had stage 4 cancer. And we got her through that as well. And she's still with us today. But it's just giving that opportunity to say thank you for coming in. I know this is tough. How can we help you next, through her frustration? So there are ways to get through it, but it's meeting them where they are, asking them, I think, what do they need just in the next 5 minutes, whether it's a breath or a cup of water, and looking at that first and adding to the next step.
Thank you.
Who did change in hygiene and lost weight. So he would wear a seatbelt to be taken to the store in the car. So Christina, that's a great example in that it sounds like part of what was important to this person was to be able to go to the store, and that the being able to put a seatbelt on was a barrier. And so I think that, really kind of helping to understand what is important to them. And it doesn't have to be long-term goals. It can be really simple things. And when we're feeling really stuck with a client, taking a step back and thinking from a importance, confidence, thinking about kind of what are the words that I'm hearing in the yeah, but, can be a helpful perspective taking. We take a lot of pride in how we do our work. And so when we are not seeing the outcomes that we want, or our clients aren't being compliant, right, doing what we want them to do, sometimes that can lead us to feel frustrated. And so thinking about that stuckness as a sign of, like, okay, I got to lean back and think about what's important to this client. What, how do they think about, do they feel like they can't do the things, or that the thing that I'm talking about, this medication, they're not confident it's going to be helpful for them personally. When we think that way, it can give us a roadmap to think about how to intervene. What does a typical day look like, right? Good question, Mary. And what do they want it to look like, right? Is that, yeah, awesome. Well, I want to kind of thank everybody. This is just a little bit of an intro, but also probably a refresher for people. When I think about motivational interviewing, this is one of those things that I like to try to take a training or a webinar, a couple times a year, to just keep it top of mind in my brain, because we kind of go back to autopilot. And I know if I'm feeling stuck a lot, that this is where I can turn. So I'll hand it back over to the hub.
Thank you so much, Katie. That was a wonderful session, and I love the discussion that's been firing up. And thank you, Ralph, so much for sharing your case and your experiences. We truly appreciate that. With that, we will move on to the next part of our session. But in the meanwhile, please keep going on in the chat. Please keep the discussion going. We are watching it, and keep sharing your insights. Karen, if you could please share the announcements from the Be Well program. Thank you so much. The Center for Substance Use Training and Telementoring provides high-quality education and best practices for responding to substance use disorders. CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals to people with SUTs. To learn more, please visit us at cstat.yudhiska.edu. Next slide. Do you have a difficult case that you or your team have encountered? CSAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our expert group of hub members and the broader learning community. There is no need to prepare a formal presentation. We will provide you a case form to fill out to assist with your case presentation. For questions or any if you want to learn more, please email us at cstat@yudhiska.edu. Next slide. Texas 2024 is officially open for sponsors and exhibitors. It is happening in Austin on Feb 29th and March 1st. If you'd like to know more, please visit texas.org/sponsor Texas. Next slide. Quick reminder, we do not have the Behavioral Health Echo next month, December, due to the holidays. Please join us at our next Echo session, Behavioral Health Echo session on Friday, January 26th, 2024. In the meanwhile, please do join us for the other echoes that are happening in December, the Harm Reduction Echo, Public Safety Echo, and the TextRx Echo. Next slide. Do you work with people in need of substance use treatment? Please join Be Well Texas for an informational session on December 11th at 3 p.m. You can, for registration, you can scan the QR code here or use the link. We'll be sharing that in the chat as well. And with that, we will move on to the next part of our session. Karen, if you could please share the case form, and Sharon, you can take it away whenever you're ready.
Thank you very much. I want to thank you so much for giving me this opportunity. And before I actually dive into it, I want to share that this was a very powerful experience for me and for my peer. Thanks to my team who helped support me as we did this, but I looked at the situation in a far greater detail. It challenged me about what I have been doing, and thanks to Amelia Murphy, she said, "Why don't you ask your peer to help you fill it out?" And because of that, we both grew tremendously. So I encourage all of you to at least fill one of these out and send it to that email. I really enjoyed this. So my peer is a 31-year-old white male, and he is currently involved in probation. And although he doesn't actually have a probation officer, somehow his lawyer is the one that referred him to the program. So he has a stipulation to complete supportive outpatient. And when he's off of supervision, May 3rd, he has an intention to return to moderate cannabis use. So the challenge that he's been having, well, number one, he had a challenge in attending supportive outpatient in a consistent way, which of course affects his treatment tremendously. But He experienced 3 recurrences of use. One was, two of them were due to crisis situations. Here, his counselor noted Pierre was experiencing a mental health crisis. He began to experience spiraling thoughts of worthlessness and suicidal ideation. Pierre reports he was experiencing deep emotional pain and that he had made a decision to soothe his pain by calling a friend to use cannabis with. Pierre stated, "It feels as though a lingering shadow is around me and I can't shake it. I know that using was a temporary solution, but I decided to do it anyway." So he has mental health issues that have landed him into inpatient treatment on more than one occasion. But his mental health is pretty stable right now. And so he said his first goal was to use cannabis in a recreational way rather than as an intervention for a crisis. But then when we were talking and going over this, he realized, I did use it as an intervention on 2 different times when I was experiencing crisis, and he felt that it was helpful. And he said that he'd spoken with his doctor about his use, and his doctor warned him against using every day because of his bipolar condition. But he feels that it is beneficial for him, and now he's kind of adjusting. He's not one of the things that he and I both discovered is he doesn't know what moderation looks like, and that's the first thing that he needs to define for himself so that he can know whether or not he's achieving his goal. And that's changing as time moves on and as we work through the process of change together. So he has his recovery capital is he has a desire to remain free from incarceration. Number one, it's a great motivator in my experience. He has family support. His parents are divorced, but he gets support from both parents, emotional and maybe even financial if necessary. He had a 13-year relationship that just ended while in treatment. Which is one of those recurrences of abuse and one of the mental health crises that what was quoted from earlier. But he did get through it, and his girlfriend paid for his apartment to the end of this year. So he has that financial cushion. He has a job that he doesn't feel that can support him, but he does have a steady job where his work is appreciated. And he's also just enrolled in training for cybersecurity. So he's taken steps to increase his earning capacity so he can live a more self-sufficient, self-directed life while he's wrapping up this legal stipulation that he has. He's very aware of his mental health condition and has had a lot of experience managing that both well and not so well. And he has a team of support, doctors, a counselor, coach, and family, of course. And he's very intelligent. Like when I was in treatment, I told him maybe I was too smart for my own good. Kind of, intellectualizes a lot of things that is a distraction from the process of change. So that's that. It looks so easy when I'm watching y'all do it, but I was really nervous. So, you know, any suggestions that you would, do you want me to go over this substance use history?
I'll jump in just to maybe a couple clarifying questions with that substance use history, and I think there might have been another question that we have from the group, so other group members chime in. Is all of that active, including things like the LSD, peyote? Is all that active use?
No,
Okay,
none of
all
it except cannabis and nicotine.
Gotcha. And from the
Although cannabis is, you know, he's only had 3 uses in the last 6 months.
understood. And does, outside of the cannabis, does he see any of his nicotine use or other use as an issue for him, problematic in any way?
No, you know, he moved from cigarette, combustible tobacco to vaping, and he's happy, at least at this stage, for that harm reduction.
Yeah, I'll let the other facilitators chime in with questions as well.
Thanks, Dennis.
Thank you so much, Sharon, for sharing the case and your patient story. I'll open up the floor for any questions or comments from our community here.
I think he also craves a fellowship of support with like-minded people. So that's something that he seems to light him up. But do y'all have any suggestions of where he could go for recovery support while also using moderately? Thank you.
Lindsay?
Yeah, I facilitate a harm reduction works group that we'd be more than happy to have them. And that's kind of for people who are doing just that, who are using, safely or want to use safely. I can drop the info in the chat if you would like. And it's on weekly, so.
Awesome, Lindsay. Thank you.
Yeah.
I had a question. I was a little unclear what the primary care doctor's, I guess, advice and recommendation was to this patient, whether that primary care doctor could be enlisted to kind of reinforce the therapy that you're trying to do.
It was a psychiatrist. He has a psychiatrist, so that he's been managing his mental health with, and according to him, the psychiatrist didn't warn him about using, but that said that consistent use could make him symptomatic, which he wants to avoid. It's very uncomfortable.
Lindsay, you had something to share?
Yeah, sorry. I also forgot that one thing that I found really helpful was when I was doing pretty well was building something like a wellness recovery action plan or plan to kind of see what it looks like when things are starting to go bad and have ideas of what I can do, and having that written down so I could see it was really helpful, because that was, when I was struggling with with substance use, that was my go-to. But you can't just take away a skill without replacing it, right? You need to have something to put there. So really just going over like what they can do in those moments and having it written down was very helpful for me.
Thank you.
Of course, I've been working with him to develop a recovery wellness plan, but I only know kind of the broad strokes of a RAP plan, and they're very proud of that training. It's very expensive, and I wish there was a barrier buster for that, so that we could more of us could be trained in helping our participants to develop their own RAP plan.
I have a friend that runs a free training that is very kind of similar. It takes some of the principles of it and helps put it into like different terms, so it's not, what do they call it? So yeah, I can drop the information for that one too. And it's a really good training.
I think I can give a summary of a few things, unless there are other questions from the community. A second there. Sure. How do you think I should proceed there?
I think we still have some time to discuss, and maybe we could, if anybody from the learning community has had a similar client that they would like to share about or similar experience, that.
Hi
I guess
there.
I have,
Oh, go ahead. Sorry about that.
I have more of a question. One of the things that I struggle with in this area is that, we're pretty close to Colorado over here in the Texas Panhandle, and we're close to New Mexico, where recreational marijuana, I guess, is legal. And so as a doctor, you sometimes don't really kind of know what to say. Is this bad? Is it not bad? I mean, I don't, I can give medical facts, but it's a very confusing atmosphere because, if it's that bad, then why is Colorado think it's fine? And so it gets hard to know what the goal is exactly.
Yeah, that is another challenge, is that so many of my participants don't see it as illegal, even though it is illegal. And they may even be working with me due to the fact that they're having some legal consequences to their use. Yet, alcohol is legal too. For some people, it's not a good idea. And, so that's kind of, how, at least while they are in intensive or supportive outpatient, that program is an abstinence-based program. So, a lot of people experience a powerful process of change just through being abstinent and engaging in their treatment over that 3 to 4 months, and their goal changes, But of course, we meet them right where they're at. Like, oh, you want to stay free? Okay, that's a great goal. What else? But while you're here, is there anything else? And how it can help you to avoid this in the future? And just kind of walk side by side through the process of change. I've never successfully supported someone into a moderation path to recovery. But I'm not going to say it's impossible, but I'll be right here while you discover, and maybe we learn together what works and what doesn't work. But it would be wonderful if there was there's actually a moderation management program for alcohol. It's a fellowship and everything, and they have parameters where he's having to figure this out by himself. And so I'm really excited about Lindsay's group, and we'll definitely tell him about that. Thank you, everyone, so much for this opportunity and for your input. I really enjoyed it. And again, I encourage you, even if you just do it, on paper or with your own team, to challenge yourself to go through a peer with this framework.
Thank you, Sharon. And Dr. Aguilar, I think you had a comment earlier.
Yes, sorry. It really was speaking to this issue that you're talking about now. I know you had said he was trying to figure out how he would define moderation for himself. And I wanted to just hear a little bit more about that, how much, if any, more than what you've already mentioned, he has discussed this particular concept of moderation for himself. Does he have an idea of what that would look like for him?
The only concrete parameters that he's been able to come up with are not buying it for himself and not using it daily so far. So there's a lot of work to be done to help him too. And a trial and error, I'm sure.
Yeah. So the parameters are not buying it for himself. And what was that second thing?
Not used daily.
Not used daily. And is he meeting those parameters now?
Yes, he is in, he's in outpatient, and, he's produced a negative, UA. And so, he's come way down from his normal, consumption, but, he wants to resume in a more controlled way, a more mindful and intentional way than just, doing what he wanted to and not really giving it thought before. Like, he wants to be, intelligent, making an intelligent decision for himself. If you do look at the drug history, he has been able to eliminate substances from his life in the past. So, of course, for some people, this is a progressive condition that, you may have been able to do that in the past, but you can't do it now. And maybe that's not the case for him. Maybe he will be able to do that. And it's only, he's the only one who can find that out.
Yeah, my sense, and I might dovetail into kind of broader considerations here, is that this is a gentleman, individual, I should say, who really wants to know as much about the situation to make the decisions for themselves. And like you said before, it's almost that there's a rationalization or way that they go about it to make the decision. What I would say is an opportunity is to provide as much education or give the chance for their network to provide as much education about a few things. One would be, what are the effects of these substances that they're leaning towards on either medications or mood? Because there is a lot of conversation that could be had there, whether it's the psychiatrist or looking up another means to see what does cannabis do to a person's mood. I think that's a deep conversation. And then underlying that, it was brought up, I think, by Ralph that the perceived harm has changed for a lot of things, not just cannabis, but also for nicotine. And I put that out there because nicotine in some areas have now been called, vaping in particular, has now been called a breath of stress air instead of a breath of fresh air. And that could be in line with some of what you talked about or wrote in the document to say, hey, I'm not feeling great at certain times. So education about those things to see, is this the potential change that he would want to see, or would that be a difference that he'd want to get to? At a bigger picture with the planning standpoint, you talked about the RAP planning, which I fully agree is a helpful place to go. A way that I frame it sometimes is the ABCs of substance use, which would be the antecedents, the behaviors, and the consequences. And you can look at that in a lot of different ways. Sometimes I have individuals look at their day from 8 a.m. to 8 p.m. and map everything out. What are you going to do? But on top of that, figure out, so you smoked, a week ago. What was going on right before that? What were you doing? What were you feeling? And then how can we rescript that moment with somebody or something else to get back on track? And I'd be curious where the vaping comes into that, given that for many individuals, 100 to 200 times a day might raise some flags. But my opening question was, did he see it that way? And he doesn't. So that's not a point to push. That might be a decisional balance point, as was brought up before, to say, how do we approach that? Where would you like to start? But the education would be good. The fact that there's relationship issues can't be ignored as well. And it's great that you and he have a very strong relationship, I can tell. And thank you for all that work, Sharon, because without that, I think this would be going in a different direction. I think it becomes a question then of how comfortable would he be in building more relationships, non-healthcare provider or non-provider relationships, because that would be a goal that could probably help with some of the emotional states that are difficult throughout this process and throughout the losses. So that's going to take time. But the biggest thing is going to be clearing things up.
I wanted to ask, these are really wonderful suggestions that I really appreciate. And I was just hoping that you could clarify for me if that is all within the role of a peer, or would I be sliding outside of my?
That's a great question. I think that there's an old book called Persuasion and Healing that speaks to that. In terms of who should be doing this with the person who needs the help. I would say in terms of the education, it would be great to get a person who has that training on the pharmacology, things of that nature. But in terms of who to stay connected to start the conversation, it all comes down to who does the person find important. And it's very clear that you have an important balance. It could be someone that Lindsay also refers to that has an important network. So to start the conversation, it comes to where's the comfort. But to delve into the specific content, I wouldn't want you alone to have to do that. And I think it's very important that he finds a network of individuals that can add to that information. If it's not that psychiatrist, maybe not, but finding other individuals that he is open to is going to be the most important.
Thank you.
Thank you. And Lindsay, I think you had a comment.
Yeah, I just want to say that, like, the way I look at it, I've been a peer for many, many years, is that really, like, you want to look at why are you doing this thing, right? Did this person ask you to do it, or are you trying to convince them of something? Because if you're in that point where you're trying to convince them of something or trying to persuade them, then that's definitely outside our role as a peer. If it's something that they have asked for and requested, of course, then I'm always happy to, help or try to find a connection to get help. But I mean, if it's something like that they haven't requested of me, that I'm just kind of trying to use to maybe persuade them to do one thing or another, then that's where we hit the problems with our boundaries and stuff.
Yeah, I fully agree. It's always the question, where do you want to start? If they say nowhere, then we can talk about the weather for a little bit and come back, and but if there's a problem that they want, that's absolutely true. That should be same for any provider.
Thank you so much. Yeah, this has been a wonderful discussion, and I think it's a great segue for us to conclude and summarize this. Dr. Antoine, if you could please summarize the case with some key recommendations for Sharon.
Absolutely. So, in summary, this is an individual who has had successes in the past with moderating and stopping cannabis use, but is looking for some suggestions and ways to be supported through their legal issues, relationship issues that have happened, and occasional substance use that's been going on that's sometimes leading to mental health issues. I think the thought process is, given that they have a connection to certain individuals, it's going to be to first identify what is the goal. And that was brought up by Ralph earlier in the talk, starting with the goal and making sure it's something that is safe. I would say would be a recommendation. Sometimes unsafe goals are requested, and that might not be the way to go. But if there is a safe goal identified, looking for information that the person might be open to incorporate into their decision process, and not just making up our own goals for them, as was talked about in the talk and by other individuals. And with that, I think it would just be making sure there's information available to have an informed decision on the part of the individual. So information about things like cannabis use and nicotine use on mental health, and also thinking about information about other support networks that could add to the great work that's being done by Sharon, because the highest predictor of success for any type of behavior change is social support. So that's always going to be the most important thing to look for. But overall, there's a lot of great work that's being done, and it's good to see that this individual is open to talking about this with Sharon, and that's a really, really key point. That connection is always going to be key.
Thank you so much for that wonderful summary. And thank you all for joining today's ECHO session. As a reminder, to earn CME credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email the BWell Texas team. We look forward to seeing you at our next session. Remember, we don't have a session next month in December. Our next session is on January 26, 2024. In the meanwhile, please do join us. Other sessions in December, we are having harm reduction, public safety, and TextRx echoes happening next month. Have a wonderful rest of your day. Have a wonderful Thanksgiving and a holiday season. Bye. You take care.